good morning, or good afternoon, depending on where you're calling in from. Thank you so much for coming and joining us for a discussion about Medicaid and managed care financing strategies that support medical respite care programs. I'm Barbara DiPietro. I'm the Senior Policy Director here at the National Healthcare for the Homeless Council. This is also a production of the National Institute for Medical Respite Care, which is an initiative of the National Council. I just want to talk a little bit about the current relevance of medical respite care, particularly in an era of COVID, and how so many communities are setting up alternate care sites and delivering services for people who are in need of protective housing or COVID-involved housing, and trying to combine these services with a model that stabilizes people and their outcomes. So I'm really excited to talk about how we can have longer-term support for these programs and be able to develop these as more of a continuum of care in our communities. So really, this is going to be a discussion about payment and how Medicaid and MCOs can pay for it, who pays for what. I think a lot of this is kind of where the rubber meets the road in our policy discussions. And so with that, I will get us started. And so today's goals, we are trying to do a number of different things. We want to specifically talk about the financing approaches for state Medicaid and MCOs and what currently is happening in that space. We want to talk about strategies for engaging staff. This is also more about just financial support and more about how we're partnering with key stakeholders that are involved in our clients' health. We want to talk about the lessons learned that people have had in working with Medicaid and MCO payments and how has that looked in the past and what can we learn moving forward. And then finally, and most important, I think, we want to facilitate a community discussion about Medicaid, the role of MCOs, and where medical respite fits generally and how this can work really well. So to that end, you will see a comment box at the end at the bottom of your screen. If you've got comments or questions for our panelists as we're moving along and talking, please enter those into the chat box. Please enter those into the chat box, and so we'll be able to draw on your comments and questions as we're moving along in our discussion. And then also, if you're having any problems, either technically or what have you, please also put those in the chat box. And Brandon Dela Cruz, our amazing technical assistant, will be helping you with that as well. And so I want to introduce you just to our panelists today, because this is really the meat of our discussion. I want to introduce Andy McMahon, who is the Vice President for Health and Human Services Policy at UnitedHealthcare Community and State. We have Pamela Kerr, who's the Program Director at the Boulevard in Chicago. And finally, we have Rhonda Hoff, who is currently the Chief Operating Officer and Deputy CEO at Yakima Neighborhood Health Services in Yakima, Washington. But in 2 weeks, Rhonda will be promoted to the CEO. So we're really excited to have her here with us today. So we are going to, basically, our agenda is fairly simple. We're just going to do some quick introductions, 5 minutes apiece, just so that Pam and Rhonda can talk about their programs, and that Andy can talk about why a health insurer like UnitedHealthcare is interested and really vested in medical respite care, and so really solidifying the interests in, from that perspective. We'll talk about a policy brief that we had published with United's support back, I think, right at the end of March, just as COVID was breaking. And so we weren't able to promote this brief the way we wanted to at the time. And so now we're really excited to be able to really push this brief and the contents that it has in it. We think it's really valuable. You can find a link to this brief in the resources box below, labeled Medicaid and Managed Care Issue Brief. And to that end also, we have another resource just so that folks are aware, the link to the National Institute for Medical Respite Care, or NIMARC. This is a new initiative of the Council for us to really be focusing on medical respite care and growing these programs nationally. Finally, we're going to have really most of our time is going to be spent on a panel discussion between Andy, Pam, and Rhonda just about how they are working with medical respite care and what our thoughts are for this field moving forward, particularly since so many things are changing. So now that you know a little bit more, though, about who we are, let's get to know about you. So this is a poll question time, so everybody gets a chance to vote. Brandon, if you could bring up our first poll question, we just want to get a sense of who is in the room with us and who we're talking with today. And so we've got a lot of options here. We really just want to know what seat are you sitting in right now? And you may be wearing a number of different hats. So please feel free to click more than one if they apply to you. And then Brandon, how will we see where the answers are coming up? Ah, very good. Here we go. And you may have to slide down on your bar just because there's so many different types of folks that are, if that's not appearing as a full box to you. Very good, thank you. And so we'll just keep going. We've got a number of folks from medical respite care programs in the health center field, so that's to be expected. Really excited to see some folks from housing or the COC funders here, certainly from hospitals and other healthcare providers. And then, okay, we'll just a minute more. Delighted to see some policy advocacy researchers. And then, of course, we have a bucket for other. So, again, we tried to be as comprehensive as we could. And so if you want to introduce yourself in the chat box below, really happy to know who's here with us. Thank you so much for this. So it looks like that's a good cross-section of folks. And then next, we want to have another poll question to get a better sense of where you are in your level of involvement with medical respite care. And so our second question just asks you, where are you? You might be new to medical respite. You're here to learn more. You might be in the process of developing something or funding and really have something active on the table. You might already be well established with medical respite. And this could be from either a provider or funder perspective. And it looks like we've got a really good cross-section of folks. So some new folks, some experienced folks. Great. I think this will make for a really lively discussion. That's wonderful. Okay, third and last poll question. Just again, we can get oriented. Are you currently receiving or providing Medicaid or MCO funding for your medical respite services? So this question may not be applicable to everyone who's in the room, but if you're a provider who's receiving Medicaid or if you're a funder who's providing Medicaid or involved in this in some way, so far, it looks like the majority of folks do not have medical respite funded through Medicaid or not involved in some way there. However, it does look like a good third of folks are currently in process. So this is something that's actively being discussed. Okay, great, wonderful. So this gives us a wonderful cross-section. Thank you so much, Brandon. We'll put those down now. And so at this point, let's just talk a little bit. I want to make sure that we are level setting. And so when we talk about medical respite care, particularly for people who are new to this, let's make sure we kind of all are just a platform of what we're talking about. So medical respite care differs from caregiver respite, which is a more commonly understood term, but medical respite care provides acute and post-acute medical care for people who are homeless. They're too ill to be on the street or in a shelter, but they're not ill enough to need inpatient hospital care. And so where do you discharge someone to that's safe and ethical so that they can get an appropriate range of services? We know that medical respite, it shortens lengths of stay at the hospital, reduces the readmission rate, and improves outcomes and lower costs. So those are, I hope, things that we're all excited about achieving in our community. And then importantly, and we'll talk a lot about admission criteria and what are the parameters for what we're treating in medical respite. This differs from skilled nursing facilities or nursing homes or assisted living or hospice, and differs from from supportive housing. This fills the gaps in between those levels of care. We right now know of about 100 programs nationally that are medical respite programs. We are seeking to grow more of those. So again, really excited to be having this discussion today. And with that, I will transition to my colleague Andy McMahon at UnitedHealthcare, who can tell us about why UnitedHealthcare is a vested partner in medical respite and what their interests are. And to be clear, from a for-profit healthcare insurer, this is something that they're committed to. And Andy, I'm excited to have you talk with us about why that is and what your vision is.
Great, Barbara. Thanks so much, and thanks so much to the National Healthcare for Homeless Council for pulling this together. We are delighted to be partnering with you all, both on the paper that we'll discuss today, as well as thinking about where we can partner with you locally on the ground to expand this critical need for medical respite. So, and thanks to all of you for joining. Again, Andy McMahon with UnitedHealthcare. Our community and state business, which is our Medicaid plan, serves nearly 6 million people in about 30 states across the country. So we have a pretty broad both geographic scope as well as, serving millions and millions of vulnerable people. That is kind of an honor for us to be able to do. And I think as we think about medical respite, it is such a critical intervention and key intervention for our members and other people experiencing homelessness who are cycling in and out of homelessness, hospitalization, ER, jails, detox, et cetera. And so really, really excited to be a part of the conversation today. Just at a really high level, and it was interesting, Barbara, when you took that poll question, I guess my challenge to myself and to all of us is that we raised at least double the number of folks who are saying they are financing and getting some Medicaid managed care financing for their respite program 6 to 12 months from now. So we may have to do another poll, Barbara, in 6 or 12 months, and as we're pushing for this. So, I think from where we sit as a Medicaid managed care plan, medical respite plays such a key role in supporting these members, and as Barbara alluded to, reducing unnecessary hospitalizations and readmission rates, et cetera. But honestly, more importantly, is setting people up in a place where they can get the care they need out in the community and set them up to success to get back into housing and back in the community so that we're not having them go through that cycle. So really the most important thing is thinking about how do we support our members who experience homelessness, who are cycling in and out of hospitals and these other institutional care settings, and connect them with the services and supports they need to thrive in their community and to improve their health outcomes. In addition to the work that we're doing nationally with the Healthcare for the Homeless Council, which we are thrilled about, we are also engaging in several of our markets, engaging with local hospitals, with local federally qualified health centers, and with state Medicaid directors. And we'll talk a little bit more about that later in terms of how do we both convene the right partners to put together medical respite programs, but then how do we pay for it, right, which is the key conversation for today. And the last thing I would just mention is that, as Barbara alluded to, right, COVID-19 only exacerbated and highlighted even more so the need that we have for medical respite. And so it is an area that we had strong interest in prior to COVID. As Barbara mentioned, we actually authored this paper before we even knew of COVID, but now certainly plays an even more critical role as we do it. So again, appreciate the opportunity, excited to be with all of you guys today, and look forward to the conversation. And I think I'm going to turn it over to Pam.
Okay, thank you, Andy, and thank you for your support of medical respite. I am Pamela Kerr. I'm the program director here at the Boulevard of Chicago. The Boulevard has been in existence for 26 years. I'm supposed to advance my own slides, sorry. Forgive me. Okay, I'm not moving. Sorry, my slides are not working. There I am. The Boulevard of Chicago. We provide a healing environment for people who are experiencing homelessness. Barbara, this is, okay, I'm so sorry, but my slides are not moving.
Oh, no, Pam, that's okay. Let me see if it works for me.
Yeah,
okay, there you go. All right,
you.
yeah, if you want to cue me, I can advance, no problem.
Okay, perfect. We provide a healing environment for those experiencing homelessness, restoring health, rebuilding lives, and actually helping them to break the cycle of homelessness. Okay, the next slide. Yeah, thank you. The Boulevard has been in existence for 26 years. We are formerly Interfaith House. We are a 64-bed respite facility. We have 49 male beds and 15 female beds. And depending on who you speak to, we're a very luxurious shelter, or they refer to it as interim housing with respite services. We believe that there is a direct link between stable housing and medical and mental health. How we are unique. The Boulevard program, like I said, we serve men and women. We have 49 male beds, 15 female beds. We have case management services. We have mental health, substance abuse, housing advocacy, medication monitoring. Everyone is assigned a case manager when they, upon intake, and that case manager works with them and follows them throughout their stay here at the Boulevard. We assist them with getting birth certificates, state IDs, applying for any benefits that they may be eligible for. We do medication monitoring. We have 3 meals a day and a snack. We provide transportation, taking them to and from their medical appointments, and assuring that they have a stable place upon discharge. Who do we serve? Our referrals come from area hospitals and clinics, the Department of Family and Support Services, which is our city services. Prior to coming to the Boulevard, our residents, they may be living on the streets, moving from shelter to shelter, or doubled up. They come with a whole host of illnesses, as you can see. They may come in with a broken arm, broken leg, and then we find out that they have other things going on. They may have out-of-control diabetes, hypertension. Cardiac illness has been a really big one for us lately. HIV, cancer. 91% actually come in with some kind of chronic illness as well. And our residents are getting older. That is one of the things that we are seeing, and they are staying with us longer. Last year, we had 61% between the ages of 41 and 61. And this year, that age group went up to 71%. And our 62 and older age group went from 13% to 21%. And so our residents are staying longer, and it contributes to, okay, can we move, Barbara? Thank you. What makes the Boulevard work? We're going to talk about that. PCC Wellness, our longstanding collaborations with hospitals, with our clinic providers. PCC Wellness is one of our longstanding clinic providers that have worked with us for over 20 years. But PCC is, if you can advance, please, Barbara, sorry. PCC Wellness is a federally qualified health center. So they see all of our residents when they come in. Our residents are seen for a complete physical when they come into the Boulevard. PCC Wellness works with them. They have 17 clinics throughout the Chicagoland area. However, they have one clinic that is actually within our facility that works directly with our residents, assuring that they are linked for primary care. If they do not have a primary care provider, they will become their primary care so that they can continue those services once they leave the Boulevard. We can advance. We do have a long-standing relationship with other hospitals and MCOs as well. MCOs are recognizing that there is a direct link between health outcomes and housing. So Respite Care decreases readmissions to hospitals and helps keep those out of emergency rooms. Many of those that are experiencing homelessness, they use, and this is what we found, is that a lot of our residents were using the emergency rooms as their primary care. If they weren't feeling well, they would go to the emergency room. And because they were homeless, they would end up staying there, and it gave them a place to stay. So our linkage that we have now, our collaboration with area hospitals and MCOs, is helping to reduce those hospital readmissions, and it's also keeping them out of the emergency rooms. Out of our 262 intakes, we had 29 that actually went back to the ER, but there were only 8 people that were readmitted at that time. And it takes time to get people out of those habits of using the emergency room as a place to stay and also using it as primary care. Where do they go? Our residents, they are staying a little bit longer, but our goal is to place everyone into an appropriate housing. We do not want to discharge anyone to the street. That is never our goal. So we are placing 27% within permanent housing. There are people that reunite with their family members, and because they're reuniting with their family members, that is giving them a better health outcome as well. We would like everyone to go into permanent housing. There isn't a lot of affordable housing at this time. So we are using other transitional housing programs, and we have very few that actually return to the hospital, but there are some people who have longer term illnesses, and they may need to be placed in and then back into the hospital and eventually into an intermediate care facility. Thank you. Our response to COVID, and like Andy was saying, this really highlighted medical respite and the need for medical respite programs, because we did get a lot more referrals and a lot more people needing respite care. But in the Boulevard, because of COVID, it has decreased our bed capacity. That was one of the things that has happened with us. We did have to decrease our bed capacity. We are a congregate living situation, and because we are a congregate living situation, we had more people that were actually testing positive for COVID. And so we are doing testing. We do testing of our staff. We do testing of our residents twice a month as well. And so as we move forward with our new normal at this point, we have a new normal, and as we move forward, we are taking intakes, and we are continuing to fulfill our mission here at the Boulevard. And so right now, I am going to turn it over to Barbara. There's my contact information. I was trying to stay under my 5 minutes because we were threatened with that. Thank you very much. We were threatened with that, but I tried to stay under. I'm going to turn it over to Barbara. And thank you very much for your time.
Thanks, Pam. I appreciate it. And then we'll turn it over actually to Rhonda, who can give us a snapshot about what she's got going on in Yakima.
Great. Thank you, Barbara. Thank you, Pam. That was great. So Yakima Neighborhood Health Services, if you don't know where we are, we're in central Washington State, so we're a little under cloud with smoke this week. So a few new challenges on top of what we've all been talking about in the world of COVID. But Yakima Neighborhood Health Services, first and foremost, we're a community health center. This is our 45th year in business, providing health care in our communities. In 2005, we were successful in our application to develop a health care for the homeless program through the Bureau of Primary Health Care. And immediately after that, we had 2 board members who began quarterly focus groups with people experiencing homelessness, asking what was needed in our community and how we were providing services to that population. At the very first focus group, the individuals told us, we need a place to be when we're sick. At the shelters, at least in Yakima, it's rise and shine at 7 a.m., healthy or not. So our board charged us with finding a solution for this problem. At the time, we didn't know what medical respite care was. This is who we are as an organization. We provide full-scope primary care services for all ages, and for people experiencing homelessness, we have additional services like supportive housing, medical respite care, and state and local funds to support additional services. Things like coordinated entry, housing and essential needs, or the HEN program, diversion and other basic needs assistance. Our homeless services represent 14% of our business and sometimes take up 90% of our time. We have 8 sites in the Yakima Valley, both rural and metropolitan communities. In addition to medical services, we provide about 80 units of supportive housing along with 3 different sites and models of medical respite care. Because of our healthcare infrastructure, our niche in the continuum of care is serving the chronically homeless, those with chronic medical and mental health conditions. Our team includes nurses, behavioral health specialists, case managers, outreach workers, and housing specialists. And you can see on the slides, this is a profile of last year. The left is representative of our clients in supportive housing, and on the right is our profile of those in medical respite care. Like Pam said, our goal is really to help people when they leave us in medical respite to transition into some kind of stable housing, but we're not doing very well at that just because of the availability of housing in our communities. If we kept everybody in our respite program until we found stable housing, we wouldn't have enough room in respite care for those with acute illnesses. So our respite care units are all standalone programs, but they're all located within a block or 2 of our various clinic sites. I was a founding member of our continuum of care about 20 years ago, And as a community, we did a needs assessment to determine the issues around homelessness and the health needs of those experiencing homelessness. It's hard to oversee a standalone program. People come and go as they please. They invite their friends to stay over, and it's not always as recuperative as we would like it to be. So this is who we serve in our medical respite program. This is sort of our eligibility requirements, or part of our eligibility requirements. We have a registered nurse that oversees the program. She performs the intake for our respite program and uses clinical judgment to evaluate our capacity to accept the patients. We have intake forms that also serve as the referral forms for primary care providers, for the community, and for hospital discharge workers. We have a resident manager in one of our programs, but not the other two, so it's a little more strictly overseen. Patients still need to be somewhat independent in their activities of daily living, and we follow the medical respite standards that we developed through the National Healthcare for the Homeless Council to set our policies. Patients do have access to support 24/7, and that's incorporated into our through our community health center model for 24/7 access. Our programs are nurse-driven, so it's primarily a care coordination model, and this is what happens where. So in the respite care program, we have a nurse and a behavioral health specialist and a case manager that are primarily responsible for the care that's provided in the various respite care programs. And then they're also responsible for making sure that the patients get to our community health center sites, sometimes on a daily basis, sometimes a couple times a week, and sometimes weekly, depending on the individual needs of the patients. In our community health center sites, we have family nurse practitioners and physicians, we have dentists, we have navigators and care coordinators, and then we also have housing case managers and employment specialists once their acute needs are addressed to help them stabilize and on their road to recovery for what happens next after they leave the medical respite program. In terms of other things that happen during the time and the scope of care that happens while they're at respite care, and in terms of our arrangements with our managed care organizations, these are the kinds of things that we contract with and assure the managed care organizations that we contract with what will happen during the patient's time in respite. So we have primarily the core team is our nurse. Typically for right now we have about 15 beds at any given time. So it's one nurse, 2 case managers, and about a 0.25 behavioral health counselor that manages those 15 clients at a time. So the care transition for those patients that are coming out of the hospital is a key component. Some of the patients are being discharged from the hospital. Many of the patients are being referred from a primary care provider in lieu of sending a patient to a hospital. The nurse is responsible for the medication review, the case management. Sometimes she's doing wound care if that's the reason that they were referred into respite, and then daily checks and health education, and then again connecting to the medical support. The behavioral health specialist is really called in as needed. If the patient has any behavioral health needs, we do PHQ-9s. That's part of our community health center intake, and so that's just folded into our respite intake as well to identify if there are any mental health needs that we need to be addressed. And then, of course, assessment of social needs, which goes with every patient that we enter into the respite program. And then you can see on the right just other standard assistance. Pam talked about family unification. Oftentimes, patients are estranged, or just our homeless community are estranged from family, and if there's any chance that we can help them stabilize at home with family or friends or extended family, we try to see if that's even possible, and sometimes it is, not often, but one is a win for us. And then when they leave the respite program, we definitely want to make sure that they have an established ongoing relationship with a primary care provider. We've also been able to do some, if we've had overflow patients when our units are full, we also make use of motel vouchers to help patients for those that we feel really need support, but our units are full. So we have several health objectives and outcomes that we measure from the Institute for Health Improvement's Triple Aim that we measure from our with our patients in medical respite, and this is just one of them. We have others that if you're interested, I would be happy to share. When we exit a patient from the respite program, we do a 30-day look back to see if they've been into a hospital anywhere in the state of Washington. The studies have shown that homeless patients who have accessed medical respite care require 50% fewer hospital readmissions following medical respite stays than patients who did not have access to medical respite. So we use in Washington, we have an emergency department information exchange, or the EDI system, and then we have a staff person that goes and looks 30 days after each patient has left to see if they have re-entered the hospital system within 30 days after leaving us. And then this is a chart that we have used for several years to look at whether or not we're being cost effective. Again, because of our relationships with the managed care organizations that we've developed, we want to show that we are making a difference. And it compares the average chart of a hospital stay in Yakima County. We use the diagnoses of depression care and rehabilitation as our comparisons for the average cost, and this was for last year, 2019. Our respite cost does not include the cost for the primary care visits, again, because ours is a nursing care model, and so the primary care visits are separate. When we can safely provide quality care for our patients needing medical oversight, we make a huge dent in the public costs associated with hospital utilization. And again, medical respite care has been shown to reduce hospital readmission rates, which reduces the costs even more. Since the Affordable Care Act in 2014 in Washington was very fortunate that we expanded our Medicaid program, 85% of our patients in respite care have been covered by Medicaid. We work with all of the managed care organizations in our county, and 3 of the 5 plans have contracted with us to care for their patients in medical respite, not because they were required to, but because we have developed great relationships with them over the years. Even though we value these relationships, it's not the best way to sustain a program. All it takes is for one of those key players to leave, and that relationship can be gone, and that funding stream then would be gone as well. So we've been shy to expand our program to meet the growing need under these circumstances. This last year, we did expand using an existing residential facility that we had already owned and another piece of land that we owned with the support of our board of directors, and we had we received some private funding as startup. So the need is very easy to demonstrate. As I mentioned earlier on one of our slides, every year we document how many people we have had to turn away because we're full. Last year it was 75 people that we turned away because we didn't have the capacity. That was almost as many people as we served. So my hope, as you can see on this slide, our big, hairy, audacious goal would be to include care coordination in our state Medicaid plan amendment for the population and other vulnerable populations to be covered as payment so that it would be based not only on a relationship, but a required benefit for Medicaid and the health plans. Knowing that we had a predictable funding source would allow us to plan better and meet the needs of our community. Our models, as you see on this slide, with some plans is a per diem rate that covers the program costs, and on another model is a global case rate based on the program costs. We're also, as Pam said, we're also seeing a growing population of seniors in our respite program. Last year, we had 15% of our patients who were 65 years old and older. I think Pam's rate was 13%. So my second big, hairy, audacious goal would be for Medicare to include medical respite as a covered benefit. And then finally, COVID, what's new for us since COVID? COVID-19 hit Central Washington State in mid-March. Now with 3 different COVID facilities, we've designated 2 of our facilities as COVID-related illnesses and 1 for non-COVID-related illnesses, and also our county has contracted with us for additional motel units to assist with that particular program. Our infection control, we've increased with PPE, with cleaning, sterilization, staff education. We've made modifications in our transportation. We have driver's barriers to help protect the staff. We're working with virtual visits, so whether it's telephone or video visits in Washington State, all of our telephones that we can provide through the state are Android phones, so they do have video capability. And then we're doing things to help our clients shelter in place. So we've created what we call Covert comfort kits. So whatever it takes, some people, like puzzles, we make sure they have televisions, card games, board games, unique things. Isolation and quarantine units, our county emergency services has asked us to help with very low-income families that are doubling up, that can't necessarily isolate within their own home. So we're doing a little bit of mission creep beyond those that are living unsheltered. And then also, I think the other piece of this is we're being very creative using trauma-informed care to help, and harm reduction to help people stay where they need to be. So we've been known to go out and purchase cigarettes for those smokers so that they don't have to go out on their own, and other harm reduction techniques to help them stay where they need to stay. And I think it's back to you, Barbara.
Okay, great, thanks. So thank you all for just orienting us to both of your programs, and Andy, to your interest in moving forward on respite. I just want to hit the key highlights on our policy brief, just so you know what the scope of it. It just describes medical respite programs for those where, again, you may be using this brief to engage new partners. Talks about the gaps in the continuum of care and the gaps in funding for this model of care. It talks about the rationale for why you would want to invest in this, particularly why insurers like Medicaid and MCOs would want to do so. It does a deeper dive into 7 programs that are currently supported through Medicaid and MCOs, and does more detail about what those payments cover, and then offers lessons learned, and then specifically recommendations for the actions that we want stakeholders to take. So I want to promote that and just give you a little bit of a bite-sized pieces here on some of the figures that we've got, and looking through the types of payments. And so for folks who are not familiar with some of these acronyms, FQHC, Federally Qualified Health Center, PMPM, a per member per month. Again, you can see that there's 5 different funding arrangements that we've uncovered or have talked through in this paper. No doubt there are others that can be explored. We're specifically focusing on Chicago and Yakima today. And then when you look at the types of services, and Pam and Rhonda talked a lot about the types of services that they offer. Those are very common in medical respite, but again, the payment may cover more or less of those services depending on your arrangement. So just with that as a quick orientation on the brief, again, we hope that you use this with your discussions so that you can be expanding programs. But at this point, we want to get to the heart of it, and it feels like even just to get here, we will try to do our panel discussion in just launching in. All of you've briefly described how COVID has changed your program. And so I'm just curious if we want to open up this discussion of what were the biggest challenges that you experienced during COVID, and where are the opportunities that you see because of this pandemic? I know you may have touched on those in your intro, but curious how all 3 of you see the current environment and the opportunities for respite. Rhonda, do we want to start with you, and then we'll go to the others?
So, sure. So thanks. So I think our biggest challenges, I think still, and these are ongoing, the first is addressing isolation with our clients that are in respite, and we've really ramped up our behavioral health staff time because they're not doing a lot on site. In some cases, they're actually doing this from outside the units. We're doing some video visits and some telephone, but because a lot of our patients do have behavioral health issues, the video or the telehealth is not real effective, and so our behavioral health issues have become a big part of it. I mentioned supporting unhealthy behaviors through harm reduction. That's been a big challenge. And then capacity. We've had, the last time I looked, we've had 65 patients in our medical respite program as a result of COVID. And so making sure that we still have room for non-COVID related patients has been a challenge for us, and making sure that we're not that we're still adhering to our mission, because we're getting a lot of requests for people who are not homeless to be able to help accommodate. We have a lot of agricultural workers here in the Valley, and so I think maintaining that balance has been a big challenge. Quickly, our opportunities have been, just because our program is becoming very well known. Our county government is asking for help, our public health department has reached out, and our Office of Emergency Management has asked us for help. And so just making sure that we're not taking on more than we can do in a quality manner.
Great. Pam, anything you want to add to what Rhonda had mentioned?
No, I think a lot of the challenges that she spoke of are the ones that we're having as well. And Rhonda, it's nice to know that you all were out buying cigarettes, because we were doing the same thing, just trying to keep everyone in. And we kept saying, oh my God, is this okay? Is this right? Because we were doing that. And behavioral health is a challenge, because we had to shelter in place. So we put TVs up in the rooms as well, Barbara. That was something we had never even thought of. So they have TVs in their rooms, and we're serving meals in their rooms. And they were becoming kind of stir crazy, for lack of a better word, at the time, because we had to have them, inside. So that has been a challenge. And because the Boulevard, we had a really big outbreak here. 32 of our residents actually tested positive for COVID, as well as 8 of our staff members. So, and that was in like a 7-week span. So that was a challenge, just trying to keep everyone healthy, and we didn't have PPE available at the time. And so just trying to get in PPE and continue to keep everyone safe. But again, an opportunity. It did shine a light on the Boulevard, which, it opened it up as far as, we were getting more referrals. There was more need for our services. So people were becoming aware of us, but that was also a challenge as well, because we did have to decrease our bed capacity in order for us to social distance as well.
Great. Thank you, Pam and Rhonda. In the interest of time, and Andy, you had said that you had nothing to add to that, just in our internal comment. Let's just go on real quick. We will pull a couple of the questions that you've put into your chat, but in the meantime, just for Pam and Rhonda, what are you currently not getting paid for in your medical respite program that I've identified as a gap that you need to get paid for? What's that gap look like for you? And Pam, why don't we start with you this time?
Okay. Oh, I'm so sorry. One of the things that when we started with our MCO collaborations, our hospitals, we're getting paid for the housing aspect, not necessarily getting paid for the services that we perform. And we do have case managers, we have behavioral health, we have housing advocacy. So these are things that we are not getting paid for. We're getting paid for the housing and having a placement beyond the hospital.
Got it. And Rhonda, how would you fill your gap?
Well, first of all, for our uninsured, we're not getting paid by anyone for our uninsured population. And so it's very specific to those managed care organizations that are helping us support their members. The other piece of that is there's an ongoing discussion of medical respite, whether it's housing or health care. And so unless we're being paid by a managed care member for their residents, then the gap really is for the operations and maintenance, because that's what their funds typically help us support.
Great. And then Andy, I know as a payer, where do you see the barriers or the challenges in the way that the Medicaid system is currently administered or funded to support medical respite programs?
So great question, and I think a significant challenge that we have for sure is, as a couple of people have alluded to, state Medicaid agencies not having these services be billable to Medicaid, which I think is a key kind of advocacy push on our end to advocate for states to add them to 1115 and or 1915I waivers so that these critical services can be paid for by Medicaid. And I would say included in that, just similar to a skilled nursing or other, the room and board component of medical respite being inclusive of a covered benefit and service in Medicaid. So I think that is honestly the crux for really being able to expand and finance more and more respite. There are certainly some opportunities for value-added services in some cases, but I think, and we're certainly being creative and trying to think about where you could do medical respite as a value-added service. That said, I think that the crux for us is advocating the state Medicaid agencies to say, this is a critical gap. It's improving health outcomes for your residents and our members. It's reducing costs and costs that are not being beneficial to our members or people, right? Just going in and out of the hospital, they're not getting better because of that. And so I think for us, the key challenge there and where we're focused is on the advocacy piece of how do we work with Medicaid agencies to do that, and then at the same time, right, can play that convening role and engage with both federally qualified health centers, hospital systems to develop these types of programs.
Great, thank you. And we did have a question come in about the inherent conflict of interest that might be present in setting up bed rates for MCOs and hospitals. And Maurice Cloutier here had just said, making sure not to double dip with members belonging to an MCO and in the hospital. I'm just guessing, Andy, do you have a sense of how to respond to that concern?
So I think that's probably a legitimate concern. I'm not sure I have a great answer to that. I mean, I think as we think about it from our member perspective, where we are trying to finance that, you know, and then I think to that point being certain that isn't getting financed twice, right? Because that honestly is just then, an additional person who could have been served either by support from the hospital system or the support from us. So I think I think it's a fair concern, but I think also one that we're able to address and mitigate quite a bit.
Okay, great. We also had someone make a comment that their MCO is not paying for respite and that the state will not pay for housing. So, of course, we know that medical respite is not housing. So, no, I just want to be very clear, we are not advocating that Medicaid pay for housing. So that should have been part of the title of this
right,
webinar.
And neither are we, right? I mean, we're saying it should be for the respite care, a la like skilled nursing, that for those room and board services while you're in respite care, which is not housing. Absolutely
correct. Right. And so the thoughts on this about in our discussion is that this is a very services-driven model in terms of the supports that people need while they're in these stays. Would everyone agree to that? Okay. And then I know we've had a number of comments or questions come in about licensing. And so I know that, that one of the things that characterizes medical respite is that often the threshold for the criteria for the admission is not such that reaches the level of nursing homes or other licensing levels that most states have. And so usually medical respites are in a kind of below that regulated licensed space. But Pam or Rhonda, do either one of you want to comment about kind of that piece of how to navigate that issue?
Yeah, so this is Rhonda. So that's exactly right. We in Washington, we don't require a license, and our criteria is if a patient had a home to go to, they would be able to recuperate at home, and so they have to be capable of taking their own medications. They have to be able to maintain the activities of daily living, and that's why before, for example, if they're coming out of a nursing home or coming out of a hospital, our nurse is actually there at the hospital to evaluate them to make sure that they're capable of recuperating in our medical respite program. We also have patients coming out of same-day surgery centers and that are recuperating just as if they were going to be sent home to recuperate, but they don't have a home. And so that's really our criteria.
Got it. And Pam, is there anything you'd add? Okay.
Yeah, and for us as well, because they have to be able to self-care. Anyone who comes in has to be able to self-care. So it is as if they had a home, they would go home. The Boulevard itself, we do not have medical staff, but we have PCC Wellness, which is our federally qualified health center, that are actually in our building that works with our residents. So we don't have to have, we don't deal with the medical piece per se. We just assure that they are taking their medications as prescribed. They're continuing their primary care wherever they are. We're just here to support them and to assist them with moving on into the continuum of care and hopefully returning to housing.
Great. And so I think one thing is just in talking through this, particularly thinking back to the poll questions where a number of folks have these negotiations in process and they are at the brink of pushing forward respite. How have you engaged your MCO partners? What does that relationship look like on the outreach? And then Andy, maybe if you want to lend into that too, what's your thought about how MCOs at the plan level can really be taking some constructive and proactive steps? And in fact, why don't we start with you on that?
Sure. So yeah, I think we are currently, trying to identify and be candidly just more intentional about trying to get organizations that are providing medical respite into our network and finding opportunities where we can proactively do that, right? All of our, as MCO, right, all of our network, we have hundreds, if not thousands, of different providers. And so I think a key component from our perspective is kind of looking at our own provider networks and seeing where we have those gaps, and if we are not contracted, trying to engage proactively with them to see if we can get them in our network, recognizing again though the issue of kind of the extent to which the services that they would be providing are billable to Medicaid, again, will be central to our ability to finance, right? As I said earlier, there's some things we could do creatively around value adds and others, but the big nut is getting it to be billable to Medicaid, and then us proactively doing that outreach, both to identify gaps in our provider network for this type of care, and then proactively engaging with them.
Great, thank you. Pam, how have you done your outreach? What do their relationships with those stakeholders look like for you?
Well, we started in the beginning when we were looking to develop relationships. We started with the social workers, because the social workers were the ones who knew of the services and knew the difficulty in placing people. But since then, we were able to speak with the CFOs and the hospital administrators and to develop those relationships, and we continue those relationships. It wasn't a one-time we come in, they see our facility, our services that we provide. We continue to foster those relationships with regular meetings and, obviously giving them the outcomes that they want for their patients that they have referred to us. So we continue to be in contact with them, almost on a weekly or biweekly basis.
Anything to add, Rhonda, to that?
Well, I guess the other thing, I don't know about anyone else on the call, but in Washington State we have what's called Accountable Communities of Health, which are regional groups that are dealing with social determinants, and our managed care organizations are very involved in those with us. So our MCOs are very involved in looking at social determinants. So most of our representatives from the MCOs have been to our programs. They've seen what we're doing, and they've looked at our information. They've looked at our data. We typically present their member data to them on an annual basis so that we can show them their results and what we've done with their members.
And if I could just add, Barbara, Rhonda, I think that's so critical, right, is being able to demonstrate the data and then that outreach, right, and that familiarity and having that relationship, because I probably should have been more clear when I was saying earlier, right, when you have hundreds, if not thousands, of provider contracts and the like, you don't necessarily know all of them super intimately, right? And so I think that creating that relationship, both on our end to proactively do it, but just to those folks that are doing it, to outreach to us too. The onus is for sure on us, but please outreach to us as well, because I think you're right that that's where, you have to have that understanding. And if you go and see and touch and feel the program and then see the impact that it's having, I think, the likelihood of, if you're not in a network, of getting into a network is higher when you have a relationship and there's an understanding of the gaps in care that you'd be meeting.
One of the things that is very clear is that we need more time for this discussion because we've barely gotten to the questions in the box. We're almost at our hours. So let's just do a final lightning round. And so Pam, we'll start with you, so you'll be on deck. What actions would you want this audience to take? Remembering back that we're a mix of healthcare providers and COC and housing and others with a pretty broad audience. Where would you like folks to be focused on their action?
To definitely realize that medical respite is a great opportunity for people, and to really advocate for the services as well, because one of the things that we realized, one of the things that we realized is that we were providing so many services, but we weren't even sharing a lot of that with the MCOs and hospitals that we were working with. So once we started talking a lot more about that, they saw more of the value in us and working with us. So just for people to realize the value in medical respite and work to fund it.
Great. Rhonda?
So I'd say the same thing. When I go in, if I'm in a room in a meeting, people know I'm going to talk about respite. And I think you make it personal, and that's how, to me, it's all about the relationships. Until it's part of the plan amendment, it's all about the relationships. And anywhere that we can talk to people about building it into the plan, that's how we're going to sustain it, so that we can increase it until we can meet the needs in our community, because that's what we need to do, is meet the needs in our community.
And then Andy, I'll give you final words.
I will join the chorus mostly, and I think in our role as a payer, I think is for us to then advocate and be very, very intentional about how we are recommending and advocating for respite services to be billable to Medicaid. And I think, and then from our end too, then it's also doing it ourselves, but then working with our other MCO partners and getting them to join in the conversation, as well as the providers. So I think, to me, I certainly see a role for us as UnitedHealthcare and other payers to help drive that conversation. But from where I sit, it's also then building that kind of advocacy coalition, that diverse coalition of providers and payers and community stakeholders to say, hey, this makes all the sense in the world to cover as a benefit.
I couldn't agree more. Thanks to all three of you for sharing your thoughts, your lessons learned, and experience. Want to make sure that we continue by ending on these action steps. Our third table in the brief, if you haven't yet downloaded that and taken a look through it, does have this chart that really outlines where different stakeholders can be rooted in their actions. And in particular, getting some federal informational bulletin or something from CMS that might encourage states on finding innovative ways to fund this, much like the tenancy support services that came out a few years ago. That's where we're focused. But there's lots of things that we can be doing in the meantime. So really hope that folks use this chart. And then also, in looking through the questions that came through the box, there's a lot here on outcome measures and data and operating issues. We have a lot of conversations about medical respite that cover specifically those topics. Today, we were really focused on the Medicaid financing piece of this and the MCO piece, but there are a lot of other topics that go into making medical respite work. So please be joining us for those other issues. We can also, there's some outcome measures and data collection that is going to be available soon. That's the result of a learning collaborative that's been going on for over a year of medical respite providers. So really encourage you to look after that. Check us out at the National Institute for Medical Respite Care. We're doing more of these promotional discussions. We have a lot of resources here and just want to encourage people to be really active in medical respite. So we are at the top of the hour. Rhonda, Pam, Andy, thank you again for joining us for this discussion. Really appreciate your leadership in this field. And with that, we will let everyone, again, really appreciate everybody coming to this discussion today. Thank you so much for being here. There will be an evaluation that pops up afterwards. Please share with us your ideas for where you want this conversation to go. And if you want to have more on Medicaid, we certainly can be continuing this conversation. So with that, I will bid everyone a good day, and thank you again for joining us. Appreciate it.
Great. Thank you all so much. Have a great day.
Thank you, everybody.